So you might be getting out of the shower, maybe just standing in front of the mirror, going about your normal morning routine, and
Wow.
suddenly you just notice this strange, unexplained bulge,
Hmm.
like right in your abdomen or maybe down in your groin. And
Yeah.
there's no prior event to explain it.
Yeah, no obvious trauma.
Exactly. You didn't like fall down the stairs. You didn't take a blunt force hit in some contact sport.
Right, right.
There's no jagged white line on an x-ray for a doctor to point at and say, there's the break.
No, it's completely different.
It's just this odd, silent, almost, I don't know, stealthy physical change. And for a lot of people, that first instinct when they see their body fundamentally changing shape without any trauma, it's just pure paralyzing confusion.
Oh, absolutely.
Okay.
It is the absolute definition of an unsettling discovery. Because,
Hmm.
I mean, we navigate the world with this deeply ingrained expectation that our bodies will, maintain their boundaries.
Right. The container stays intact.
Exactly. Our skin, our muscles, our skeleton, they are the container. And when that boundary suddenly seems to shift or like warp from the inside out, it feels deeply unnatural.
Yeah, it's freaky.
It really is. But the
Yeah.
reality is the human body, while remarkably resilient and adaptable, is ultimately subject to the very strict, unforgiving laws of physics,
Hmm.
specifically the physics of pressure and structural integrity.
Right. And that is exactly what we are focusing on for today's deep dive. We've been poring over the research, specifically this really comprehensive briefing on hernia causes and surgical repair.
Yeah, it's a great source.
It really is. And, the most striking realization for me is that we are not talking about a disease here.
No, not at all.
We aren't talking about a virus or a bacterial infection or some, cellular mutation.
Right.
We are talking about pure structural engineering. It's an architectural failure that just happens to be occurring inside a biological system.
That's a perfect way to phrase it.
So before we get into how modern medicine patches the breach, we really need to understand how the wall was built in the first place, right? And why it ultimately fails.
Well, if you look at the human torso, right, from your ribs down to your pelvis, you are essentially looking at a pressurized biological cylinder.
Okay, a cylinder.
Yeah. Your abdominal cavity houses your stomach, your liver, your intestines, your reproductive organs, all of that.
Mm-hmm.
And all of it is held in place by what we call the abdominal wall.
Right.
Now, it's really easy to picture the abdominal wall as just like that six-pack muscle, the rectus abdominis,
Yeah.
like a solid shield of armor.
Yeah, like Batman's chest plate or something.
Exactly. But that's a total misconception. It's actually this highly complex, multi-layered weave.
A weave.
Yeah. You have muscles running vertically, horizontally, diagonally. And weaving all of those muscles together, encasing them, is a tough, fibrous connective tissue called fascia.
Okay, fascia. Let's unpack that for a second because that word gets thrown around a lot in fitness and medical circles. But what exactly is it doing in this specific context?
So think of fascia like, well, like the white fibrous casing on a sausage.
Oh, gross. But okay.
I know, right?
Yeah.
Or, that incredibly tough silvery layer you sometimes have to cut off a piece of raw steak.
Yeah, the part you can't chew.
Exactly. It is a dense web of collagen that wraps around every muscle fiber, every nerve, and every organ.
Hmm.
In the abdominal wall, this fascia acts as the primary load-bearing material. The muscles provide the movement, right? They let you bend, twist, sit up.
Right, right.
But the fascia provides the sheer tensile strength to keep your internal organs from just spilling out.
Wow. So it's like a heavily woven fabric.
It really is.
In fact, while I was digging into the research, I kept coming back to this analogy of a heavy canvas backpack. Like the kind you might take on a long, rugged hiking trip.
I like that.
Yeah, because the canvas itself, which would be your fascia and muscle weave, is incredibly strong. It can hold a tremendous amount of weight. But a backpack isn't just one continuous, seamless sphere, right?
Right, it has pieces.
Yeah, it has seams, it has zippers, it has places where different panels of the canvas are stitched together.
And those seams in the human body represent the inherent structural vulnerabilities.
Ah, okay.
As strong as the abdominal wall is, it has natural weak points.
Yeah.
These are areas where the tissues naturally converge, or where there are literal gaps in the muscle wall that are designed to let other structures pass through.
Right. And if we look at the most common types of hernias mentioned in the source material, they map perfectly onto these natural
Yeah,
seams.
absolutely they do.
You have the inguinal area, which is the groin. You have the umbilical area right around the belly button.
Right.
And you have the hiatal area, which is higher up, where your esophagus passes through your diaphragm to meet your stomach.
Exactly. Let's take the inguinal canal as an example, because
Right.
inguinal hernias are just incredibly common, especially in men.
Right.
So during fetal development, the testicles actually develop inside the abdomen.
Wait, really? Inside?
Yeah, high up in the abdomen. And as the fetus grows, the testicles descend through the abdominal wall down into the scrotum, passing through what is called the inguinal canal.
Huh. I had no idea.
Yeah, and once they pass through, that canal is supposed to close up tightly behind them. But it leaves this tiny natural defect, a tiny spot where the muscle weave just isn't perfectly solid.
So it's literally a built-in weak seam in the canvas backpack.
Precisely. And the umbilical area is the exact same concept. That is where the umbilical cord passed through your abdominal wall when you were in the womb.
Oh, sure. That makes sense.
Right. It closes up after birth, but the scar tissue there, your belly button, is never quite as strong as pristine, unbroken muscle and fascia.
So, okay, keeping with the backpack analogy, let's say you are carrying a really heavy, hardbound book inside that bag. And that book represents your internal organs, or I don't know, maybe a pocket of abdominal fat. And that book happens to be pressing right against that weakened seam in the groin or the belly button.
Hmm.
Because the abdomen is a pressurized cylinder, there is constant outward force. So what happens? Over time, the seam gives way,
No.
the canvas fibers separate, and the corner of the book starts bulging through the gap. The book is still mostly inside the backpack, but it is physically pushing through the primary barrier.
That is the exact mechanism of a hernia.
Wow.
The internal tissue just seeks the path of least resistance. When a defect opens up in the fascia, the pressurized contents of the abdomen will inevitably exploit it.
Because the pressure has nowhere else to go.
Exactly. The tissue pushes through the muscle wall and it comes to rest right under your skin. And that is what creates that mysterious, unexplained bulge you see in the mirror.
But here's where I have to push back a little bit, or at least play devil's advocate for a second.
Sure.
Because if my fascia is literally tearing, right? If a piece of my intestine or a glob of fat is shoving its way through my muscle wall, why doesn't it hurt?
That's the trap.
The literature clearly notes that many hernias are completely 100% painless at first. But isn't pain our body's evolutionary alarm system?
Usually, yes.
If I tear a hamstring, I know it instantly. If I cut my finger, the alarm blares. Why is the alarm completely disconnected when my abdominal wall suffers a structural failure?
It's a brilliant question, and it speaks to the incredibly insidious nature of this condition. You
Oh.
have to look at how pain actually works in the human body.
Okay.
Pain is essentially an electrical signal sent to the brain when a nerve ending is compressed, stretched, severed, or exposed to, like, inflammatory chemicals.
All right.
Now, when that seam in your muscle wall first begins to separate, it often happens on a microscopic level. It's
Yeah.
not a sudden, violent tear like a hamstring snapping.
Oh, wait.
Yeah, it is a slow, gradual widening of a tiny gap.
Like a slow separation of the fibers.
Exactly. And the first thing to slip through that newly widened gap usually isn't a highly sensitive piece of intestine.
What is it then?
It is often a tiny, malleable piece of omentum.
Omentum.
Yeah, which is basically a specialized layer of fat that hangs in front of your organs.
Yeah.
And fat just doesn't have a dense network of sensitive pain receptors.
Ah.
So if this soft, squishy fat slips smoothly through a small hole in the fascia, and it doesn't happen to pinch or rub against any surrounding nerves in the abdominal wall, there's simply no physical trigger to sound the alarm.
The breach is entirely silent.
Completely silent.
So the book has pushed through the canvas, but it hasn't snagged the zipper or caught on anything sharp.
That's it. Your brain is not receiving any data that says, warning, structural integrity compromised,
Yeah.
because the nerves just aren't reporting an immediate crisis.
That is fascinating, but also, mildly terrifying.
Yeah, it is.
Because it completely lulls you into a false sense of security. You see the bulge, you poke it, it doesn't hurt, so you assume, hey, it's just a weird body thing, I'll just ignore it.
And that is exactly the trap. A lack of early pain absolutely does not mean harmlessness.
Right.
The architectural defect is there. The hole exists. And here is where the physics become just relentless. Once a weak spot opens in a pressurized cylinder, the pressure will continually, endlessly exploit it.
It's never going to leave it alone.
Never. Every time you take a deep breath, every time you stand up from a chair, every time you laugh, you are manipulating internal pressure. The hole will never, ever get smaller on its own.
Yeah.
The laws of physics dictate that it will only be subjected to outward forces that want to stretch it further.
Which brings us to the critical tipping point.
Right.
If the body's pain alarm is effectively disabled in the early stages, what eventually trips the wire? How does this silent, painless oddity transition into a problem? And, at what point does it escalate into a full-blown medical crisis?
Well, the transition from silent to symptomatic usually happens as the dynamics of the pressure change, or as the hole itself gradually stretches. The first most obvious warning sign is, of course, the visible bulge. But there is a very specific, almost bizarre characteristic of a classic early-stage hernia bulge.
Which is?
It often completely disappears when you lie down.
Okay, yes, I read that, and my immediate thought was, that feels like a cheap magic trick.
It really does.
Like you have a physical golf ball-sized lump on your groin, you lie back on your bed, and it just vanishes. It dissolves into nothing. What is mechanically happening there?
It is entirely a function of gravity and hydrostatic pressure. When you are standing upright, walking around, the entire weight of your digestive tract and your internal organs is being pulled downward by gravity.
Right, into the pelvis.
Exactly. And at the same time, your core muscles are engaged just to keep you upright, which squeezes everything inward.
Okay.
So that combination of downward pull and inward squeeze forces the contents of your abdomen directly against the lower abdominal, right where those weak spots in the groin usually are.
So it's like squeezing a water balloon from the top, right? All the water rushes to the bottom and bulges out wherever the rubber is the thinnest.
That's exactly.
Yeah.
But the moment you lie flat on your back, you completely alter the physical environment.
Because of gravity.
Yes. Gravity is no longer pulling your organs down into your pelvis. It's pulling them flat against your spine.
Oh, interesting.
And your abdominal muscles relax.
Yeah.
The internal pressure drops to its lowest possible baseline. Without that constant, aggressive outward force pushing the tissue through the hole, the piece of fat or intestine simply slides backward.
It just falls right back in.
It falls back through the gap and returns to the main abdominal cavity.
So the book just slides back inside the backpack.
Right. And this is a crucial concept for you to understand if you're listening. A disappearing bulge is not a sign that the hernia has cured itself.
It's not a magic healing trick.
No, not at all. The tear in the fascia is still there. The structural defect is identical. You have simply temporarily removed the pressure that makes it visible. The very moment you stand up and gravity takes over, the tissue will slide right back into the hole.
So it's not healing, it's just playing hide and seek.
Exactly.
And eventually, hiding isn't enough. The symptoms start to escalate. The research points out that patients begin to feel this heavy, dull, dragging sensation in the groin or abdomen. And specifically, they start feeling actual pain when lifting heavy objects or when coughing.
And this is where the silent breach finally starts setting off the alarms. To understand why, we have to look at a cough not as a respiratory symptom, but as a violent mechanical event.
Right, because we usually think of a cough as just, clearing our throat.
Yeah, but physically, it's a massive, coordinated muscular explosion.
Wow.
It is a phenomenal generation of force. When you cough, your diaphragm, which is the large dome-shaped muscle under your lungs, violently contracts downward.
Okay.
And simultaneously, your abdominal muscles clench inward. You are drastically reducing the volume of the abdominal cavity in a fraction of a second to force air up and out of your lungs.
Which means the pressure inside has to spike.
Exactly. It causes the intra-abdominal pressure to skyrocket almost instantaneously.
So if you have a perfectly sound, untorn abdominal wall, that pressure spike just bounces off the tight fascia. The fabric holds.
The fabric holds, and the energy is directed exactly where it needs to go up through your airway.
But if you have a tear...
Right. If you have a hernia, a literal hole in the fabric, that massive explosive pressure spike acts like a sledgehammer hitting that exact weak point.
Oh, wow.
It brutally forces the internal tissue against the edges of the tear.
And that is when it hurts.
Exactly.
Because now you aren't just slipping a soft piece of fat smoothly through a gap, you are violently stretching the torn edges of the muscle.
Or pulling on the fascia, which, unlike fat, is heavily innervated. It has a lot of nerve endings.
Ah, so that's where the pain signal comes from.
Yes. The tissue is being forcefully shoved into a space that is too small for it. The nerves surrounding the tear are being stretched and irritated.
And what about that dragging sensation?
The dragging, heavy sensation comes from the constant low-grade tension of tissue hanging outside its normal anatomical position, just pulling on the structures inside.
Like a dead weight.
Exactly. But the sharp pain during a cough or a heavy lift,
Hmm.
that is the body finally recognizing that the architecture is actively failing under load.
But even that sharp pain from a cough is just a warning, right? It is not the ultimate crisis.
No, it's not.
The literature outlines a specific, highly dangerous scenario. It mentions severe emergency signs, sudden, intense, agonizing pain, accompanied by nausea and vomiting.
Yes.
And it uses a word that immediately sets off alarm bells: strangulation.
It is one of the most frightening words in structural medicine, and it is a true life-or-death emergency.
Okay.
To understand strangulation, we have to look at a precursor condition called an incarcerated hernia.
Incarcerated, like being locked in prison.
That is exactly what it means. Normally, as we discussed, the tissue can slide in and out of the hernia defect. You stand up, it pops out, you lie down, it slides back in. We call that reducible. But what happens if a larger loop of intestine gets pushed through the hole during a massive pressure spike, say, lifting a heavy piece of furniture, and it gets stuck?
Because the hole isn't big enough for it to easily slide back.
Right. The tissue swells slightly from the friction, or the muscle wall spasms around it, and now the intestine is trapped outside the abdominal cavity.
Wow.
It is incarcerated. It cannot be pushed back in.
So the book has pushed through the tear in the canvas, but the canvas has aggressively tightened around the middle of the book. It's locked out.
It is locked out. Now, an incarcerated hernia is incredibly painful and requires immediate medical attention to try and safely push it back. But if it cannot be pushed back, the clock starts ticking towards strangulation.
And what exactly is that?
Well, strangulation is a microscopic, minute-by-minute biological horror story.
Walk us through that. What is physically happening to the tissue when it strangulates?
The intestine, like every organ in your body, requires a constant supply of oxygenated blood from your arteries, and it needs your veins to carry the deoxygenated blood away.
Okay, plumbing 101.
Right. Both the arteries and the veins have to pass through that exact same tiny, tight hole in your muscle wall to reach the trapped loop of intestine.
So they are essentially running through a choke point.
Exactly. Now, veins have very thin walls, and the blood pressure inside a vein is very low.
Okay.
Arteries, on the other hand, have thick, muscular walls, and the blood pressure from the heart is very high.
Oh, I see where this is going.
Yeah. So when the muscle wall clanks down on the trapped intestine, what gets crushed first? The low-pressure veins.
So the blood can't get out.
The exit route is completely blocked off. But the high-pressure arteries are still pumping blood into the trapped segment.
Oh my God.
Blood is rushing in, but it cannot leave. The trapped loop of intestine begins to engorge. It swells massively with trapped fluid.
And as it swells, it takes up even more space in that tight hole, which just makes the squeezing worse. It's a vicious cycle.
A catastrophic positive feedback loop. As the swelling becomes extreme, the pressure inside the trapped tissue eventually becomes so high that it overpowers the arterial pressure.
And then the arteries shut down.
The arteries are pinched completely shut. The blood supply is severed. Zero oxygen is reaching the cells.
And without oxygen, cells die.
They die rapidly. This is strangulation. The sudden, intense, blinding pain that the literature describes is the agonizing neurological cry of tissue that is actively suffocating and dying.
And the nausea and vomiting. Why does a structural problem in the groin cause someone to violently throw up?
Because if a loop of intestine is trapped, swollen, and dying, it is completely blocked off. It's a total bowel obstruction.
Yeah.
Food, liquids, gastric juices,
Yeah.
they can no longer pass through your digestive tract. The entire plumbing system backs up completely. The stomach has nowhere to send its contents, so it violently ejects them upward.
Wow. Okay. That is incredibly sobering. And this is exactly when the sources say you must seek immediate emergency care, right? If you feel that sudden severe pain, you do not wait.
You do not wait. You go straight to the ER.
Right. It is a stark timeline. From a painless, invisible defect to a manageable structural oddity to a sudden, catastrophic tissue death.
It escalates very quickly at the end.
Yeah. So, if a patient recognizes this timeline, if they feel that dragging sensation and realize they have a compromised wall, the inevitable next question is, how do we fix it?
Right.
Because as the biomechanics we just discussed make abundantly clear, hernias do not heal on their own. The body cannot unstrangulate a bowel.
No.
It cannot sew its own fabric back together while it is constantly under pressure.
It is biologically impossible. The normal biological mechanism for healing a cut or tear Requires the two edges of the broken tissue to rest closely together, completely tension-free.
Like when you get a cut on your arm.
Exactly,
Right.
so that the body can build a fragile bridge of fibrin and scar tissue across the gap. But in a pressurized biological cylinder, those torn edges are constantly forcefully being pulled apart by your breathing, your movement, your organ weight.
So they never get a chance to meet.
Exactly. The body's microscopic construction workers cannot build a bridge across a chasm that is constantly expanding.
The mechanical forces are just too great. So surgical intervention is the only permanent, viable solution. A human doctor has to go in and act as the tailor.
That's right.
Let's break down how they actually patch this hole. The research outlines two completely different philosophies of repair, and the contrast between them is fascinating.
Yes, the evolution of this surgery is a brilliant study in mechanical engineering versus biological trauma. And what is truly remarkable is the efficiency of it all.
How so?
Well, in a standard non-emergency scenario, the entire procedure, putting the patient under anesthesia, locating the anatomical defect, reducing the hernia by pushing the organs back into place, physically repairing the fascia, reinforcing it, and closing the skin takes roughly 30 to 60 minutes.
That's it, 30 to 60 minutes, which is astonishing when you consider that they are performing high-stakes structural carpentry on living soft tissue.
It's incredibly fast.
So let's look at the first technique mentioned, the open hernia repair. This is the traditional time-tested method.
Yes.
The surgeon makes a single, relatively large incision directly over the site of the hernia. They physically open the skin and fat, locate the tear, push the tissue back, and fix the muscle.
This is the direct, unvarnished approach. To use your analogy, it is the equivalent of taking the backpack, unzipping a large hole right next to the torn seam, putting your hands entirely inside the bag to shove the book back into place, and then physically sewing the canvas closed in front of you.
Very hands-on.
Very. It provides the surgeon with unparalleled direct tactile access. They aren't just looking at a screen. They can feel the tensile strength of the fascia with their fingers. They can manually assess the health of the tissue.
But then modern medicine introduced the second option, laparoscopic surgery.
Right.
The minimally invasive approach. Instead of slicing the abdomen open with a scalpel, they make 3 or 4 tiny keyhole incisions.
Oh.
They pump the abdomen full of carbon dioxide gas to inflate it like a balloon, creating a workspace. Then they slide a long, thin, high-definition camera through one hole and specialized, elongated surgical tools through the others.
It is a complete paradigm shift. Instead of opening the front door to tear down the drywall, the surgeon is essentially sliding microscopic tools through the mail slot and doing the renovation from the inside out while watching their own movements on a large 4K monitor.
And the benefits of this laparoscopic method are massive, right?
Oh, huge.
Less trauma to the abdominal wall means significantly less postoperative pain.
Yes.
The tiny incisions mean smaller scars and a much lower risk of wound infection. And critically, it offers a much faster return to normal activity.
That's the big one for most people.
Right. Now, if I'm a patient, especially an active patient, someone who plays sports, lifts weights, or just wants to get back to their life without being bedridden laparoscopic, seems like the undisputed obvious choice.
It definitely does.
In fact, let's talk about those active patients for a second. The research highlighted that laparoscopy is uniquely suited for them. I mean, there's a story I was reading the other day, actually, about a guy, let's call him Mark.
Okay.
Mark was this huge CrossFit guy, constantly lifting heavy. He gets an inguinal hernia.
Classic.
Yeah, classic. He opted for laparoscopic surgery specifically because his surgeon told him the recovery of the muscle wall would be less traumatic. And within a few weeks, he was walking, then doing light mobility, and eventually he was fully back to his normal weightlifting routine.
Yeah, that's exactly the kind of outcome you want.
It's amazing. So with success stories like that, why wouldn't everyone in every single scenario choose the keyhole method?
It's a very common question, and patients often come into consultations demanding laparoscopic surgery. But the literature explicitly states not everyone is a candidate.
Why not?
The reasons why are deeply rooted in the gritty, physical reality of the human interior. Laparoscopy relies on clean, open, navigable space inside the inflated abdomen. If the surgeon slides that camera in, they need to be able to clearly see the defect and maneuver their tools.
So what ruins that clean space?
History.
History.
Specifically, a history of previous abdominal surgeries. Anytime the human body is cut open for an appendectomy, a C-section, gallbladder removal, the body heals by forming internal scar tissue,
Mhm.
We call these adhesions.
Adhesions.
Yeah, adhesions are dense, sticky, fibrous bands of tissue that can literally glue your internal organs together or glue your intestines to the abdominal wall.
So if you've had multiple surgeries, the inside of your backpack isn't a neat open compartment anymore.
Exactly.
It's a tangled, sticky mess of cobwebs and glued together canvas.
Precisely. If a surgeon tries to slide a sharp metal instrument blindly through a keyhole into a dense forest of adhesions,
Right.
they run a massive risk of accidentally puncturing the bowel or slicing a major blood vessel that is hidden within the scar tissue.
Oh, wow. That sounds awful.
It is wildly dangerous. So in those cases, the surgeon must use the open method so they can visually and manually identify and carefully cut away the adhesions safely.
That makes total sense. You can't navigate a maze in the dark with long chopsticks. You have
Yeah.
to open the roof and look down.
Yeah, that's a great way to put it. Additionally, if the patient presents in the emergency room with a strangulated hernia, where the bowel has been trapped and choked off like we talked about, laparoscopy is often inappropriate
Because they need to move fast.
because the surgeon needs immediate wide-open access to visually inspect the trapped intestine. If a segment of the bowel has turned black and died from lack of oxygen, the surgeon has to immediately transition into a bowel resection, cutting out the dead tube and sewing the healthy ends back together.
Right.
You cannot reliably or safely perform complex emergency bowel reconstruction through tiny keyholes while the clock is ticking.
So the choice of surgery isn't just a menu option. It is dictated entirely by the biological and structural reality of the patient's specific damage. Now, before we talk about what the surgeon actually puts inside the hole, I want to touch on preparation.
Sure.
Because the source gave some great advice for patients preparing for surgery. And I think this is so practical. There's almost like a checklist of home preparation steps you should take before you even go to the hospital.
Yeah, that pre-op prep is crucial for a smooth recovery.
Right. Like it says you should set up your recovery space beforehand, put essential items at waist height so you don't have to bend down or reach up.
Because stretching will pull on those incisions.
Exactly. And doing laundry ahead of time, having loose-fitting clothes ready, and maybe prepping some meals so you aren't standing over a stove for an hour the day you get home.
Yes, all of that. Big one too.
Yeah.
You do not want to fall when your core is compromised.
Oh, yeah, that would be a disaster. So, okay, you do the prep, you go in. Regardless of whether the surgeon is standing over an open incision or manipulating joysticks looking at a monitor, the core of the repair usually involves something called a mesh. And I want to pause on this concept because it seems like it's the linchpin of modern hernia surgery.
It absolutely is. The introduction of surgical mesh revolutionized the durability of hernia repairs.
Let me run an analogy by you.
Okay, let's hear it.
When I read about how they use this mesh, I immediately thought of home renovation, specifically patching drywall.
Oh, I like this.
Let's say you trip and punch a fist-sized hole in your living room wall. You don't just take a tub of wet spackle and try to fill the empty space.
No, it just fall through.
Exactly. The spackle is essentially liquid.
Yeah.
It has no structural integrity on its own. It will just plop through the hole and fall down inside the wall cavity.
He needs a foundation.
Right. So you take that sticky, woven fiberglass tape, the drywall mesh, and you stretch it across the hole, sticking it to the solid drywall on either side. You've created a bridge, a scaffold.
Mm-hmm.
Then you spread the spackle over the mesh. The mesh provides the raw, unyielding tensile strength, and the spackle integrates with it to create a smooth, solid wall.
That is an exceptionally accurate visualization of what surgical mesh achieves. Now, let's look at what happened before mesh existed.
Okay.
A surgeon would find the hole in the fascia, pull the two torn edges tightly together, and sew them shut with heavy thread. We call this a primary suture repair.
Which sounds logical. You rip your jeans, you sew the denim back together.
It sounds logical until you remember the pressurized cylinder.
Oh, right.
The moment that patient wakes up from anesthesia, coughs to clear the breathing tube, and tries to stand up, massive mechanical tension is placed directly across that single line of stitches.
Yikes.
And remember, the tissue they are sewing together is already weak, degraded fascia. That's why it tore in the first place.
Oh, man. So you have a highly pressurized force pulling against tight threads sewn into weak, fraying tissue.
Exactly. And the physics are brutal. The tension causes the sutures to literally tear right back through the patient's soft tissue. It's the classic wire cutting through cheese effect. The stitches rip out, the hole rips wide open again, and the hernia violently recurs. Historically, the failure rate for primary suture repair of large hernias was unacceptably high.
Enter the mesh.
Enter the mesh.
But wait, I have to push back here. We are talking about taking a piece of synthetic plastic like polypropylene or polyester and permanently sewing it inside the human body.
Yes, we are.
Doesn't the immune system completely freak out? Doesn't the body identify this plastic square as a foreign invader and launch a massive inflammatory attack to destroy it?
It's a highly sophisticated biological interaction, and you are right to ask about the immune response. When the mesh is first placed, the body absolutely recognizes it as a foreign object.
Right.
The immune system dispatches white blood cells, specifically macrophages, to the area to attack it. But modern surgical mesh is biologically inert. It doesn't break down, and the immune cells can't destroy the synthetic polymers.
So they just give up.
The body pivots to a completely different biological strategy.
Yeah.
It decides, if I can't destroy this thing, I will encapsulate it. And this is the true genius of the mesh design. The mesh is not a solid sheet of plastic. It is highly porous, like a screen door or your drywall tape.
Ah, so it has thousands of tiny holes.
Yes. And over the weeks following the surgery, the body's repair cells, fibroblasts, begin migrating through the pores of the mesh.
Through the holes?
Exactly. They start laying down vast amounts of raw collagen. The patient's own biological connective tissue aggressively weaves itself in, around, and through every single pore of the synthetic plastic.
That is mind-blowing. The body essentially swallows the mesh and adopts it as its own tissue.
It becomes a permanent, deeply integrated hybrid material. It is no longer just a plastic patch sitting on top of the muscle. It is a reinforced, impenetrable biological wall.
That's incredible.
The mechanical load of the intra-abdominal pressure is now distributed widely across the entire sheet of mesh, rather than pulling on a single line of vulnerable stitches. The wire cutting through cheese problem is entirely solved.
Which brings us perfectly to the aftermath. The patient wakes up. They have this intricate, hybrid, drywall tape repair inside their abdomen. The surgery took an hour, and they are usually sent home the exact same day, which, again, feels crazy for a major structural overhaul.
It is pretty remarkable.
So what does the road to recovery actually look like, and, where do people screw it up? Let's compare those typical recovery times.
Okay, well, the surface-level recovery is deceptively rapid.
How so?
Because of modern pain management and minimally invasive techniques, many laparoscopic patients feel surprisingly good within 48 to 72 hours.
Really? That fast?
Yeah, they're walking around making coffee, feeling like themselves. Open surgery takes a bit longer because the incision is larger, maybe a week or two before they feel that mobile. But the acute surgical pain from the incisions fades quickly in both cases.
That's good news.
But this rapid reduction in pain creates what is arguably the most dangerous psychological phase of the entire process.
The illusion of being fully healed?
Exactly. The absence of pain does absolutely not equal the presence of structural integrity. The literature outlines a critical window full recovery, meaning the biological integration of the repair takes 2 to 6 weeks.
Okay, 2 to 6 weeks.
Yes. And there is a massive neon flashing caveat attached to that timeline. Patients must avoid all heavy lifting and strenuous core activity.
Okay, let's play out a hypothetical scenario to understand why that 2 to 6 week window is so treacherous.
Let's do it.
Let's say it's day 10 after a laparoscopic mesh repair. I'm the patient, I'm feeling great, zero pain. I decide it's time to move a 50-pound bag of dog food from the trunk of my car to the garage.
Oh boy.
I bend over, I grab the bag, I hold my breath, and I heave it upward. What is physically happening inside my abdomen at that exact second?
It is a recipe for catastrophic structural failure.
Really?
Yes. At day 10, the brilliant biological integration we just talked about, the fibroblasts weaving collagen through the pores of the mesh, has barely even begun. The collagen is immature, soft, and weak.
Oh, right.
The only things keeping that piece of mesh firmly in place over the hole in your fascia are the surgeon's mechanical tacks or sutures.
The tiny stitches?
Yes. So when you hold your breath and heave that 50-pound bag, you generate a colossal spike in intra-abdominal pressure.
And that hits the mesh.
That pressure slams into the mesh. Because the body hasn't cemented the mesh in place yet, all of that kinetic energy is transferred instantly and violently to the tiny surgical stitches anchoring the corners.
Oh.
The tension exceeds the holding power of the soft tissue. The stitches forcefully rip out of your muscle, the mesh is blown out of position, the hole is completely uncovered.
And it all pops back out.
And instantly your intestines forcefully bulge back through the defect. The hernia has recurred, and the entire surgical process is ruined, simply because you could not respect the biological timeline.
That is a brutal visual, but it makes the point perfectly. The surgeon performs the mechanical fix in 1 hour, but the patient is solely responsible for protecting that fix while the biological integration takes weeks.
It's a partnership.
It is entirely a partnership, and it highlights why the literature is so insistent on the patient following postoperative directions to the letter.
Now, even if the patient is a perfect partner, they rest, they don't lift the dog food, they walk gently, there are still inherent risks.
Right, I mean, every surgery carries risk.
Exactly. The literature lists some common surgery risks and complication signs that patients need to watch out for.
What are those signs?
Well, infection's a big one. You want to look out for a sudden fever, increased redness around the incision, or if the wound feels hot to the touch.
Okay, fever and redness.
Yes. You also have to watch for excessive pain that doesn't get better with medication or sudden swelling, and of course rare complications from anesthesia or chronic nerve pain if a nerve gets irritated.
And infection with a mesh sounds particularly bad.
It is. Infection is a mathematical risk whenever you break the skin barrier and introduce a foreign body-like synthetic mesh into the sterile environment of the abdomen. If bacteria colonize the mesh before the body can encapsulate it, it creates a chronic, deeply embedded infection that often requires a second surgery just to remove the infected mesh.
Oof, that's awful.
And swelling, well, that's just the body's natural inflammatory cascade, rushing fluid to the trauma site to deliver healing cells. But if it's extreme, it's a complication sign.
Good to know. But the literature has a really interesting concluding thought to the section on risks. It says, quote, choosing an experienced surgeon significantly reduces these risks.
Yes, it does.
Now, obviously, nobody wants a rookie operating on them, but why is the literature emphasizing it here? What is it about hernia repair specifically that makes the surgeon's individual experience the ultimate variable?
It comes back to the concept we opened with, structural craftsmanship.
Craftsmanship.
Yes. Hernia repair is not a simple, robotic, paint-by-numbers procedure. Every single patient's interior anatomy is slightly different.
Okay.
The exact geometric shape of the tear, the precise degree of tissue degradation around the edges, the location of hidden nerves, these are all variables that cannot be fully known until the surgeon is inside.
So they have to improvise and adapt on the fly.
They have to make highly complex spatial and mechanical judgments in real time. An experienced surgeon knows exactly how to size the mesh so that it overlaps the defect by precisely enough margin to prevent the tissue from slipping around the edges.
Right.
They know, intuitively, exactly how much tension to apply to a suture too loose, and the mesh shifts too tight, and the stitch strangles the tissue, causing necrosis and pain.
Wow, it really is an art.
It is. They understand how to identify and carefully avoid the delicate sensory nerves running through the groin, which, if accidentally snagged by a stitch, can leave the patient with debilitating chronic nerve pain for the rest of their life.
It really is the difference between someone who has patched drywall once by watching a YouTube tutorial and a master plasterer who understands exactly how the materials will behave under stress years down the line.
That's a perfect comparison.
The technique, the pure physical craftsmanship of the surgeon's hands is the primary defense against long-term complications.
Absolutely.
Okay, so we've covered the architectural failure, the silent warning signs, the ticking clock of strangulation, the surgical tailor coming in with open or laparoscopic mesh repairs, and the psychological trap of the recovery window.
It's a lot to take in.
It is. But let's look at the long game now.
Okay.
Whether a patient is actively trying to protect a brand new surgical repair that is still in that vulnerable integration phase, or whether they are simply listening to this and trying to prevent their body's fabric from ever tearing in the first place, we need a defense strategy.
Right.
How do we actively, consciously manage our body's internal pressure on a daily basis? I mean, are there lifestyle changes to lower future hernia risks?
Yes, there are. The literature provides a very clear list of prevention and lifestyle tips. And at first glance, to the average reader, they might just seem like a random assortment of generic boilerplate health advice. Well, it lists maintaining a healthy weight, avoiding heavy lifting or using proper form, treating chronic coughs, and eating a high-fiber diet.
Right. If you just scan that list in a doctor's office, your eyes glaze over. Lose weight, lift with your knees, eat a salad.
Yeah, exactly.
It sounds like something you'd read on a poster in a school nurse's office. But based on everything we've meticulously broken down today regarding the physics of the human body, these aren't just generic wellness tips, are they?
Not at all. If we connect this to the overarching mechanical reality we've been discussing, we can synthesize every single one of these seemingly disconnected lifestyle tips into one grand unifying theory: the active, conscious management of intra-abdominal pressure.
Pressure management.
Exactly. Every item on that list is a highly specific, targeted physical strategy to reduce the sheer mechanical stress on your abdominal fascia.
Okay, let's break them down mechanically, piece by piece. First on the list, maintaining a healthy weight.
Right.
Now, from an engineering perspective, how does carrying extra adipose tissue or body fat physically cause a hernia to form?
Well, extra abdominal weight acts as a constant, relentless 247 physical load on the structural container. Think of the abdominal cavity like a balloon.
Okay.
The more volume you pack inside that balloon,
Yep.
whether it's enlarged internal organs or a significant layer of visceral fat, the greater the baseline outward pressure pushing against the rug.
Baseline tension is permanently elevated.
Exactly. If you are 50 pounds overweight and you're
Yeah.
carrying that weight entirely in your midsection, you are forcing your fascia to maintain a massive outward resistance every single second of the day.
Wow.
You're permanently stretching the fabric.
Mm.
Over years and decades, that relentless static tension slowly degrades the collagen bonds in the weak spots of the groin and the umbilicus.
So it just wears it down.
Yeah, it's the equivalent of permanently overstuffing a canvas suitcase until the zipper finally just pops off the tracks.
It's a failure of sheer endurance. Okay, that makes sense. The next two on the list are avoiding heavy lifting or using proper mechanics and treating chronic coughs. Now, if excess weight is a chronic static load, these two seem to be the opposite.
Yes, these are dynamic, explosive loads. We discussed the brutal mechanics of a cough earlier.
Right, the sledgehammer.
Exactly. A chronic hacking cough, perhaps from smoking, asthma, or severe allergies, is subjecting the abdominal wall to a violent, high-grade pressure spike dozens or hundreds of times a day.
Man, when you put it like that.
It is like taking a physical hammer and repeatedly striking the exact same pane of glass. Eventually, it shatters. By medically treating the root cause of the cough, you are, in effect, confiscating the hammer.
And lifting mechanics. Everyone always says, lift with your legs, not your back. But how does that actually protect the front of my stomach?
It comes down to lumbar flexion and core bracing. When you bend over at the waist with straight legs and pull a heavy object upward, your spine curves and your abdominal muscles instinctively bear down to try and stabilize your torso.
Right, you crunch down.
Yeah. You are essentially crushing the front of your abdominal cavity together, forcing all the internal pressure downward and outward directly into the inguinal canals.
So you are squeezing the water balloon incredibly hard from the middle.
Precisely. Proper lifting technique, the hip hinge, dropping your hips, keeping your spine neutral, bracing your core statically. It distributes the kinetic force of the heavy object through your powerful glutes and leg muscles, rather than forcing your abdominal wall to absorb the compression. You are bypassing the structural weak points.
That biomechanical breakdown makes perfect sense. But here's the tip that truly caught me off guard.
Oh, the fiber.
Yes, the dietary twist. The literature explicitly lists eating a high-fiber diet to prevent straining. Who on earth would naturally, intuitively connect eating more broccoli or oats to preventing a literal tear in their muscle wall?
I know, it seems like a bizarre correlation until you look at the biomechanics of human digestion. It is a brilliant example of how deeply interconnected the body's mechanical systems are.
Break it down for us. What does fiber have to do with fascia?
A diet low in dietary fiber almost inevitably leads to constipation, because fiber is what draws water into the digestive tract to give waste material volume and a soft, passable texture.
Okay.
When an individual is constipated, they are physically unable to move waste through the final stages of the colon easily.
Yeah.
So to compensate for this, what do?
They strain.
Right. They sit on the toilet and they strain.
They hold their breath and push.
Yes. They are performing what we call a Valsalva maneuver. They take a deep breath, close their airway, and violently contract their diaphragm and abdominal muscles to artificially generate massive downward pressure to force the bowel movement out.
They're weaponizing their own respiratory muscles against their abdominal floor.
That is exactly what they are doing. They are consciously, purposefully generating an explosive intra-abdominal pressure spike that is directed entirely downward into the pelvic basin and the groin. And if they are chronically constipated, they are subjecting their inguinal fascia to this brutal, localized mechanical stress every single day, Repeatedly straining during bowel movements is actually one of the single most common direct mechanical causes of inguinal hernias.
That is why.
By simply introducing adequate fiber and hydration into the diet, you change the physical viscosity of the waste.
And then the body just does the work.
Exactly. The digestive system functions smoothly via natural peristalsis, the automatic wave-like muscle contractions of the intestines.
Mm.
The individual never has to strain.
Right.
By eating fiber, you completely remove the most damaging daily repetitive mechanical stress from the equation. You save your structural integrity by changing your diet.
It is so incredibly empowering to look at health advice through that lens.
It really is.
The literature simply states small lifestyle changes can make a big difference. And when you casually read that, it sounds like a total platitude.
Sure.
But when you understand the reckless physics behind it, you realize it is profound mechanical engineering advice. Eating fiber isn't just about wellness or digestive comfort. It is a highly targeted structural defense strategy for your abdominal wall.
Knowledge is only truly valuable when it is deeply understood and then applied.
Very true.
Once you internalize the fact that you are the caretaker of a highly pressurized, fragile biological system, every single choice you make, how you position your feet to lift a box, how much visceral fat you carry, whether you treat a lingering winter cough, what you eat for breakfast, it all becomes a conscious tool to protect your architecture.
I love that perspective. Okay, as we reach the end of this deep dive, let's do a quick, comprehensive flyover of the journey we've taken through the human body today.
Sounds good.
We started by completely reframing our understanding of a hernia. We realized it is not an illness, it is a physical breach. It is the heavy book pushing through the weakened seam of the canvas backpack. We learned that because fat has no sensitive nerve endings, the initial tear is often a completely silent, painless oddity. A strange bulge that plays a magic trick by vanishing when you lie down and relieve the hydrostatic pressure.
But we also explored the terrifying reality of the tipping point.
Yes, we did.
The fact that the laws of physics will continually exploit that weak spot until the day the tissue becomes trapped. And we walked through the microscopic nightmare of strangulation. When the low-pressure veins are crushed, the tissue swells, the high-pressure arteries are pinched off.
Right.
And a manageable structural defect transforms into a literal life-or-death emergency where a piece of your bowel is suffocating and dying.
We looked at the sheer mechanical reality of the fix. Since the pressurized fabric won't magically stitch itself together, we need surgical intervention.
Right.
Whether it's the direct, unvarnished approach of open surgery necessary to navigate a minefield of scar tissue, or the incredible space-age keyhole techniques of laparoscopic surgery for a faster recovery, doctors have to act as tailors. And they patch the hole using a porous synthetic mesh scaffold that the body's immune system ultimately adopts, weaving its own collagen through the plastic to build an impenetrable wall.
And finally, we discussed the absolute necessity of the patient's role.
So important.
The psychological discipline required to protect that repair during the incredibly deceptive, pain-free 2 to 6 week biological integration phase. And the lifelong necessity of managing intra-abdominal pressure through weight control, proper lifting mechanics, and the surprising structural defense of dietary fiber.
The core message to take away from all this research is highly optimistic, though. Modern surgical techniques are incredibly safe, efficient, and durable, provided you do not delay treatment when you notice the structural failure, and provided you actively manage your pressure dynamics afterward.
Yes.
Do not ignore the silent breach. Early action is always the best action.
I think there is a broader, perhaps more philosophical takeaway here as well. Something for the listener to seriously consider beyond just the clinical mechanics of a hernia.
Oh.
Think about the concept of wear and tear in our daily lives. We are incredibly proactive about maintaining our external structures and possessions.
That's true.
We religiously change the synthetic oil in our car engines to prevent friction. We reinforce the foundations of our homes. We patch the tiniest leak in the roof before the drywall is ruined. We actively seek out, identify, and reinforce the weak spots in the non-living things we own.
We are hyper-vigilant with our property.
Yet we frequently, almost chronically, ignore our own body's structural warning signs. We dismiss a painless, vanishing bulge in the mirror. We push through a sharp, dragging pain in our groin when we lift something, assuming the human body will just infinitely adapt to the abuse.
We just hope it goes away.
We wait until the structure literally breaks through the wall, until the biological alarm is deafening, until the tissue is literally dying before we finally decide to intervene. We demand undeniable proof of the failure before we act.
We demand the X-ray with the jagged white line.
Exactly. So I would leave the listener with this final provocative thought.
Let's hear it.
If your body's fabric was subjected to a sudden, extreme, unforeseen stress test today, say you had to rapidly sprint and lift a massive weight in an emergency, where are the unseen, unacknowledged weak points you've been carrying around? Are you actively, consciously reinforcing your internal architecture every day, or are you just blindly waiting for a seam to tear?
Wow. That is a phenomenal grounding question to end on because I guarantee, the next time you are standing in front of that mirror getting ready for your day, you won't just be looking at the smooth surface of your reflection. You'll be thinking about the unbelievably complex, pressurized, woven architecture holding it all together.